somebody I met through you just gave us a term sheet for our B round. They're based in Dubai, but had a family office in New York City, and then started a larger fund that's based out of Dubai. And so that's news within the last week. But we do have a convertible note that we're raising right now just to get us to profitability. So are you able to pull up the presentation? Yeah, and I think the best way to start is maybe go right to 18. That's really where we have like product, because it's evolved quite a bit. Yeah, keep going, keep going. Yeah, there you go. So just by way of introduction, I am a physician by training. Went to UC Berkeley for undergrad. I'm a Texas native, based in Austin. And went to UC Berkeley, chemistry and economics, then Columbia University in New York City for medical school. I did an immunology fellowship at Harvard, at Brigham and Women's, Mass General, was promoted to faculty there. And then I had the opportunity to restart the clinical division in immunology at MIT. And so I really as a young doctor, was more academic focused, and then had, wouldn't say an opportunity. My ex-wife really didn't like the cold, and basically told me if I wanted to stay married, we have to move someplace warmer. So we moved back to Texas, where I know. I started a small practice, me, 2 employees, grew it to 350 employees, 23 locations, 4 states. Still own that, but I hired operators to take over that and do the day-to-day about 7 years ago. And it's given me the opportunity to develop what I thought at the time is the future of medicine. And it's a complete end-to-end virtual care platform. And so now next slide. Really focused on increasing access to healthcare and lowering healthcare costs, which a lot of people say, but we really wanted to set out to execute on that vision. And so to do that, we created a consumer-facing app that's iOS, Android, as well as a web app. And then when you think about it, it's really a patient portal to an electronic medical record. And so we didn't want to license somebody else's EMR. We wanted to custom build it so it would have all of the integrations that I thought would be essential for the future of healthcare. Allowing somebody in a non-traditional location to be able to have biometric data going to the providers, medical diagnostic tests immediately available at the fingertips of providers, so that whoever that virtual care provider is, they could make good decisions and utilize their prescriptive authority. And so to that end, we've got about 30 patents awarded, another 30 pending. The EMR that we built is meaningful use compliant, high trust certified, GDPR compliant. We've licensed it to Siemens, to Quidel. We're going through the FDA with Quidel on about 5 different FDA applications that link our software directly to their in-home COVID test, their in-home flu test, their in-home COVID combined with flu, and in-home strep test. So when those get approved and you buy them at a CVS or Walmart or wherever, the software that will be linked to those tests directly, well, it's our software, and it directly links to our provider network. We've also integrated with an interesting device called Nonagon device, FDA-approved device, company out of Israel, that has 9 different functions. It takes a medical grade image of the eardrum, medical grade image of the back of the throat, collects heart and lung sounds, bowel sounds, pulse oximetry, temperature, but then it also has Bluetooth connectivity to an EKG, a scale, and a blood pressure cuff. And that allows, if you have that in your home, us to do essentially the quality of a physical exam you'd get in a doctor's office, especially when you combine it with the in-home tests. And so Nonagon, we're the exclusive virtual care provider for them in North America. And they go into CVS in Q1, Target at the end of Q1, Walmart in Q2. So we'll have broad distribution of our platform through our partnership with Nonagon. And then on the EMR side and some of the capabilities that it has, the World Health Organization licensed it for the World Health Summit in Berlin last year. And so the platform itself is very sophisticated. It's been acknowledged by large companies as well as the WHO. And we're really proud of what we built. And now the next slide. In terms of what we offer to consumers, we have our own MDBox platform. So if you go to MDBox right now, mdbox.com, you can download the app, you can use the web app, you can do 2-way virtual care visits, asynchronous chat in all 50 states. And then as we get these FDA approvals for the machine vision, we'll turn those on our backend admin platform. So when I do demos, I can show people how to use the machine vision to auto capture results for these in-home tests, but that's not FDA approved yet. The Nonagon device is operational, so you can buy that directly online right now. through Fluent or through their own marketplace, the Nonagon marketplace, but it'll be in retail locations in Q1. And then most of our traction right now comes from either white labeling our software and provider network, so virtual care as a service. And we offer it both as a immediate use white labeled solution, where if you just give us your logo and your color palette, you can be up and running in 4 hours. So a lot of small independent pharmacies that want to be able to generate more prescriptions, so they just want an on-site telemedicine solution, go with that. But our larger national partners do the fully integrated version. So we have a full suite of APIs that people can use to create a customized look and feel. So our biggest partner currently is Hy-Vee. They're a grocery store chain in the Midwest. They write 22 million prescriptions annually, 357,000 prescriptions a week. And they wanted to stand up a platform that could directly compete for elective prescriptions, you know, hair loss, smoking cessation, erectile dysfunction, premature ejaculation, skin conditions, hair conditions, to compete with like a Get Rome and a Hims Hers. And we created a platform for them called Redbox RX. That's live. So you can go to redboxrx.com. Most of our volume is coming through that platform right now, while some of these other partnerships that we have get busier. And next slide. Yeah, and so this is just an example of what, you know, a typical synchronous video visit looks like. And we were really ahead of the curve on this. Pre-pandemic, telemedicine, you know, wasn't even two-way video visits weren't even legal necessarily in all 50 states. You had to first establish an in-person face-to-face relationship. Teladoc, Amwell, Doctor on Demand, MD Live, they did the heavy lifting with the regulatory lobbying that they did to enable what we do. But even Teladoc at the time, pre-pandemic, 1 year, 6 months pre-pandemic, had a very unsophisticated platform. You know, a lot of their visits were phone calls. Their two-way video visit was using legacy software. And at that point, we had already developed our system in all of our software. It's custom built, it's our own, it's not licensed, with the ability to either do two-way video or even more complicated video visits where we pull in family members, team members, social workers, specialists, so we can have up to 20 people in a synchronous video visit. And then next slide probably shows our asynchronous chat. And so a lot of our providers don't actually like this function. Patients love it. Every now and then I've got 40 medical licenses, and I like to jump in and actually see patients. In fact, while I was tuning up in the room next door, I went ahead and did a couple of visits, somebody from Kentucky, somebody from Ohio, somebody from Texas. And the asynchronous chat allows a patient to initiate a visit, go through basically a differential diagnosis generator engine, and enter in their symptoms. And then predictively, through an algorithm, we ask the common questions. So before I actually get engaged, I already have kind of a sense of what the patient visit should be and what prescription they're looking for. And then at that point, if I have questions, I ask them the questions that are medically relevant to make sure that if there are any red flags that would prevent them from getting the treatment that they're desiring, that I have a medical reason for doing so. And sometimes there's a lag, you know, so somebody texts, by the time that I get to it, it's been 5 minutes, 10 minutes, whatever it is. And then they get busy, you know, with their life. And so they might not check back in for an hour. And so we thought this asynchronous chat was going to be something super easy to do, and that our providers would love it. Our providers hate it. They do it, but you might have 20 chats going at once before you finally reach the endpoint where you're going to give a prescription or make a diagnosis. And so it's super convenient for patients, really hard on providers. So we definitely try to push people towards two-way video. No. So these are all U.S. licensed providers. They're either MDs, DOs, or nurse practitioners. And so we worked with Jones Day on a 50-state regulatory policy, and our back-end admin platform ensures that we're always being compliant. So in some states where a supervision ratio on a nurse practitioner might be 7-to-1, and some it's 12-to-1, and some it's 5-to-1, all of that is engineered on the back end to make sure that we're always in compliance. That's a great question, though. Yeah, 100%. Yep. Yeah. So for the company that is offering us to take a lead on the B round, They have virtual care contracts with governments, with UAE, with Saudi Arabia, with Nigeria, with Colombia and Latin America. And so they want to use our platform to plug into their existing missions and then take advantage of, they already have provider networks, but so they can just log in and take the visits. But for more complicated cases or cases where you have somebody paying cash, maybe executives that are in Dubai for a multinational company, they just want to talk to a Harvard-trained doctor. They want to talk to a US-based cardiologist, in which case we can link them to ours. And then there are the regulations that allow it are peer-to-peer consultation rules. And so where there is a doctor that's based in Dubai that's officially the doctor on a case, but then they're pulling in a consultant US doctor. And so we definitely are doing that for what we're doing down the road in Q1, Q2 with Tiller Health Dubai. But yeah. Yeah, and if you have that little toolkit, if you have a Nonagon device in your home, you're really not compromising the quality of healthcare. I mean, if you actually do any other two-way video visit, there's no way through a camera to know what's going on in the back of somebody's throat. You don't know what's going on in their ear. You're not hearing their heart and lung sounds. So the quality of the visit that we're getting is on par with what you get in a doctor's office. And I would even argue it's higher quality because of the time and attention that goes into each visit. A lot of times when you go into a busy doctor's office, it's really just a churn, and you've got a medical assistant that maybe doesn't do the level of the intake that we require for our virtual care visits. Right now, it's all our own providers. So everybody that works with us is, right now, 2/3 of them are actually W-2 employees. That way we created what we call the minimal viable provider network so that we can cover 50 states 24/7. And then the rest of them that come on our contractors like Uber drivers. And then we definitely have a product platform that we want to offer to doctors' offices so that we can do their after hours triage. That really hasn't started yet. We haven't put any marketing into it. But if you're a doctor's office and you're seeing patients from 9 a.m. to 6 p.m., you can use our software for free during the day if you want to use it. And then at night, when you clock out, instead of having a phone that just says, if it's after hours and it's an emergency, call 911, call us back in working hours. Everybody's gotten that message before. We can take those visits, and there is actually a way to incentivize those practices. So instead of them paying for our service, they get paid for it, because really what we're doing is generating an office key for them. It's still their practice. We're providing the contracted services, but they actually get whatever that margin is. And so it's something that we're looking to do in Q2, but we just have so much opportunity right now. We have large contracts with national pharmacy chains that we're trying to execute on. And just past weekend on Saturday, we launched our Journeys. Journeys is going to be a product that takes people on specific wellness journeys: weight loss, smoking cessation, drugs of abuse, diabetes management. And we launched weight loss, and we had it up for about 30 minutes, and we took it down because we had 30 people subscribe to, and the profit margins on that are just so much better. It's $150 a month for the weight loss journey. And right now, I don't know if you guys have seen any of this in the press, but these GLP-1 agonists like Ozempic, Mounjaro in Australia, it's FDA certified both for diabetes type 2 and weight loss. And there are so many people using it for weight loss, the diabetics can't get this drug. In the United States, you can still get it. And the interesting thing was we barely had it up a couple of keywords, and we had not yet put the rest of our platform together. We're going to launch that in about 6 weeks. We thought maybe we would get 3 to 5 people in that time interval enroll, and so many people enrolled that we had to just manually see these patients, two-way video visit them, but we don't have the journey tools that we're going to be launching in the next 4 to 6 weeks that check in with them on a daily basis, where they give us their weight on a daily basis, their calorie count, any side effects. So we're just going to brute force these 30 people, but we took the platform down and we're going to launch it in earnest in 4 to 6 weeks. Yep. Yeah. We're already, Ahold, which is who manages Giant, Martin Eagle, but they also do Stop and Shop, and they're already under contract with us. So in Q2 next year in Giants in Pennsylvania, we're going to be rolling out a hybrid of what we're doing, where they're going to have some on-site through their pharmacy, where they'll have our tools and they'll be able to do visits through the pharmacy. But then they'll also be offering the non-Agon device and virtual care visits from home. I mean, I think that as we have more conversations with payers in the future, that people will push towards this. The downside to payers right now is that, pre-pandemic, it was great for them. They offered the service to everybody, telemedicine visits, and the utilization rates were so low that it was very profitable for them. Right now, the telemedicine utilization rates have gone up so much, they actually lose money. And so they're trying to figure out that balance between quality profits for themselves and patient care for the people that subscribe to their insurance plans. And so, if everybody has this tool, it's so convenient to be able to use it. The fear that they have is that it's just going to increase the number of visits. Well, yeah, so we in the platform have it built in so that if you do, say, an acute care visit, not one of these chronic wellness journeys that we already have it scheduled out. But if you do a flu visit, a COVID visit, you're being checked in on a daily basis where you can say, I'm fine today, and you just push a button and you won't hear from us. But if you say that you're doing a little bit worse, we can ping you, you can push a button to initiate a two-way video visit and you get a discounted follow-up. Maybe we can go back just to the investment opportunity. I would go back to like slide 7-ish. And just show, exactly. Yeah, there we go. And so like next slide, yeah. So this is just showing Hyvy. So Hyvy, we just started in January, had a couple hundred visits. That September hasn't been updated. So we thought that in September, we were gonna see about 2,200 visits. We actually saw 3,000. And we're on pace to hit 4,000 this month. So we just had really dynamic growth just with that one partnership. They just got approved. Marshall, the president of Hyvy Pharmacy, runs the Redbox RX operation. And he just got $4 million in marketing to take us to 20,000 visits by May or June. And that basically, our break even is at right around 700 visits a day. And so we should be profitable with their infusion of marketing capital without any other partnerships. But we've got Quest Diagnostics, we've got Femtech, which is a really interesting story. I mean, Kimon Angelides was the founder of EOS Health, rebranded it when he hired Glenn Tolman as Livongo, and Livongo sold to Teladoc for $18 billion, $18.9 billion. So Kim started a women's health platform called Awesome Woman. And so we're the virtual care platform behind awesomewoman.com. Their first two commercial partnerships start in January. So we're expecting a lot of volume from that. Nonagon's going to bring us a lot of volume. They think they're going to sell 100,000 devices in 2023. So if they're anywhere close to that, they're even a tenth of that, it's going to really increase our volume and traction. So next slide, we should do this year around 5 million in top line revenue. But our break even is going to be probably in May or June. And then we think we're going to do 20 million just with the 3 partnerships that I highlighted there. We've got a lot of other partnerships coming online. Yep. It's mostly family offices and a couple of incubator funds. So like Texas Capital Factory. I went through a Harvard Medical School accelerator, and so they invested. Then there's QVT Capital is a family office out of New York. They're far and away our largest investor. And the next slide. Yeah, and so we've got a B term sheet that Tiller Capital Dubai offered us $15 million at 120 pre-money, but we're doing a bridge right now at a $25 million pre-money. So it's a great opportunity for somebody to come in, and we've already funded 7.6 of it. We're looking for 12. And so if anybody has any questions and want to reach out to me, they can email me directly. And we're hoping to close it in the, and just by way of that difference, the next 5 that comes in should take us to profitability. Yep. That is for that. Yeah. It's mostly doctors. Yeah, there's no technology investment that's required at this point. I mean, we have, we've spent $30 million building this platform and doing the regulatory and the IP behind it. And so it's really where it needs to be, but there's maintenance that goes on, and any customizations we do for partners, we give SOWs to them, statements of work, and they approve it, and then they pay for it, and we put in a little margin into it. So the maintenance of the platform is very little. We're talking about AWS hosting fees and any iOS updates, Chrome updates, whatever it is. So it's really, our use of funds is for marketing, for our MD Box platform and our Journeys platform. It's also for just hiring the providers so that we can scale and actually handle 20, 50,000 visits a month. Right now, we can handle about 10,000 visits a month with our existing workforce. Oh, for sure, yeah. I mean, like that was day one. I mean, I've put my medical licenses at stake, my medical reputation. So a big part of our spend was just working with, I mean, it wasn't just Jones Day. I mean, we worked with 5 or 6 national law firms to make sure that on a state-by-state basis, we're compliant from a regulatory point of view. And that's not just in terms of the practice of medicine, but it's also in terms of marketing claims. It's also in terms of the anti-kickback from some of our partnerships with folks, and as well as just the physician oversight of mid-levels. Yeah, so I mean, we had some offers that we've already turned down, but we are looking to find an opportunity to either sell to a large strategic or potentially go public in the next 24 or 36 months. It was a lab test developer, and they have a presence. They have some products out in retailers that are over-the-counter kind of cough and cold homeopathic type medications, but then they made a large run at COVID lab testing, PCR. So they were flush with cash, but they just weren't a good fit for us. And the valuation that they gave us was less than what we closed our Series A. So our Series A was led by Quidel. Quidel is the second largest US point of care test manufacturer behind Abbott Labs. They just acquired Ortho Clinical for $6 billion. And we're going through the FDA with them, like I said, on like 5 different in-home tests that rely on our software. And so it just was one of those things where at the moment, we felt like our revenues were undervaluing us relative to the market traction we have, the contracts, and the intellectual property we have, and we just weren't desperate at that point. So. Oh, no, it's patent. So we have 30 approved patents. We've got 30 pending. A lot of them have to do with the software, how we do the device integrations, the machine vision system that we developed. It can read in-home tests more accurately than a human eye. When you think about the pregnancy test, everybody's familiar with an in-home pregnancy test. That's a market that's defined by how many days after you're pregnant can you tell. So a $20 EPT Clear Blue first response can tell you you're pregnant 5 days sooner than a 99-cent generic that you can get at Walgreens or CVS. And yet 80% of the market is those $20 tests, not the 99-cent generics. We can take our vision system to a 99-cent generic and improve the sensitivity so that you can tell you're pregnant sooner with that cheap test than with these expensive name brand tests. And if we actually take our vision system to the name brand tests, we can improve their sensitivity. We just haven't taken the time, energy, resources to get a partnership in the pregnancy testing market. But we also have IP around some devices that we created. We have a microfluidic device that, if you were in a nursing home or a non-traditional setting, you're not actually in a hospital, or you're being cared for at home and you're elderly and you have some dementia, you can't tell if somebody is confused, disoriented, if they've got, it's just a progression of their dementia, or if they're delirious because they have an infection. And you don't always have a fever when you have an infection, especially when you're elderly. And so a lot of times those patients are transported at no small expense to an emergency room where they get a urine culture, a blood culture, sometimes a spinal fluid culture, sometimes imaging. And then they're put on shotgun cocktails of antibiotics, 3 broad classes to cover everything. And these are already patients on a lot of medication, so there's drug interactions. You're generating superbugs because you're just broad spectrum covering them. And with the little device that we've patented with an appropriate sample of blood or urine or spinal fluid, you can run it through a microfluidic panel and use machine vision to actually look at markers on the surface of the bacteria to say this is E. coli that's in the urine. And then the next thing that happens is on the same chip, it gets gated through a series of channels with antibiotics pre-coded at increasing concentrations. So in about 45 minutes, you can do what takes days to weeks in a hospital, where you identify an organism and then you identify the appropriate antibiotic coverage. And that same type of chip can be used in solid cancer tumors, where while you've got a patient on the operating table and you take a tumor sample, you send it to pathology, and it takes time to identify what it is. We can do it with markers through these microfluidic channels and say this is the type of cancer that's there. But then we can also run those cells through increasing concentrations of different types of chemotherapeutics. And now you'd have to clinically validate it. A lot of time and investment would go into that, but that's IP that we could license. I mean, so we actually have a slide on it. If you go back two, maybe three slides. And so you can look, it depends on what go back a couple more. Oh, is that one? Okay, sorry, go the other direction. Another one. There we go, back. Yep, there you go. So yeah, it depends on which segments you're looking at. If you're looking at just the ambulatory care visits that can be addressed by telehealth, you're talking about 28 billion. I mean, there's 550 million office visits for the top 5 reasons people go to unscheduled visits to either an urgent care emergency room or their own primary care doctor's office. You know, things like sore throats, I think I have a UTI, I have a cough, I don't know if I've got COVID versus pneumonia versus asthma. And so you can displace that with virtual care very easily. That's 28 billion, that's low hanging fruit. But then on the pharmacy side, the virtual visits that you can do that lead directly to prescriptions is another $75 billion. And then with the integrated devices is the difference that takes you to 250 plus billion. Yep. Yeah. Yep. Yeah. There are so many ancillary revenue opportunities. Right now, HHS has a program they want to end the COVID pandemic. And so they have funding in place without having to send COVID tests to every single home. They're transitioning to allow doctors to do COVID testing on every Medicare patient twice a week, reimbursed at 12 per test, 25 per patient per week, but it has to be initiated by medical practice. And so people are doing the same type of thing with virtual care. Going to a doctor's office, say, if you bring the patients, we'll do the virtual follow-up on the COVID test and we'll split the revenue with you. I mean, there are a lot of creative ways to use the platform. Yep. Yeah, thanks for having me.